Good morning, everyone. And today, our topic in pediatrics is about thyroid disorders and disorders of sexual development in pediatrics. So, first of all, I will talk about the thyroid disorders, and later on, I will talk about the disorders of sexual development. In thyroid disorders, of course, same like internal medicine, there could be uh, hyperthyroidism and there could be hypothyroidism, right? So in pediatrics, the important topic among these is hypothyroidism. So now, or you can say congenital hypothyroidism is the important topic. Why? Because the incidence is more of congenital hypothyroidism. Now, as we know from our um, knowledge about the thyroid disorders or the function of thyroid is simply thyroid hormones act on every cell of the body, and when the thyroid hormone are not normal, like what I'm saying is hypothyroidism is there, of course, like what will happen that there will be abnormal development. You can see over here congenital hypothyroidism. It is the thyroid deficiency which is present at birth, and it is the most common preventable cause of mental retardation. A very very important point, or you can say a most common cause, preventable cause of intellectual disability. Now, this is the prevalence, like in India or in worldwide. So, like hypothyroidism is more common than hyperthyroidism. That's why I am talking about hypothyroidism first of all. First, like I'm talking about this, and this is like twice common in girls compared to boys. You can see over here, 3 to 4 weeks of gestation, what happens, like the thyroid gland develops, and 20 weeks, synthesis and secretion begins, end of first trimester. The thyroid releasing hormone and thyroid stimulating hormone are detectable, and between 18 to 20 weeks, like hypothyroid pituitary thyroid axis activity is low. So, of course, when it is low, so until this time, the fetus is depending on transplacental passage of maternal hormones. Like the maternal hormones are those which is crossing the placenta and fulfilling the requirements simply. Now, as far as the classification is concerned in this one, of course, like congenital hypothyroidism, uh, it could be primary, it could be central, it could be transient. So, of course, when the problem is in the thyroid gland, we call it as primary. Whenever above thyroid or central CNS, hypothalamus or pituitary, we call it a central. Or transient hypothyroidism is like when it is a short-lived or it goes away by itself simply. There are many reasons behind that. For example, uh, most of the cases are sporadic, which are due to thyroid agenesis or dysgenesis. And 15% of the times, it is hereditary. So you can say 85% sporadic cases, which are due to thyroid dysgenesis, and 15% of the time it is uh, hereditary. So hereditary is simply when uh, hereditary is simply when it is some inborn error of thyroid synthesis. It is this thing. And what are the causes of transient hypothyroidism is simply um, this one I'm talking about. It is maternal antibody mediated, or it could be due to iodine deficiency, for example, in developed country, in developing country, or for example, if the mother is taking some anti-thyroid drugs, so the effect of that drug, is causing hypothyroidism. So, of course, like this one doesn't need any treatment because this one is the transient one, and this one is going to go away by itself simply. So, this is like you can say uh, the classification with the causes. So, primary, of course, it is due to some thyroid dysgenesis, and hereditary is the one which is basically due to what you can say some inborn error of metabolism, and transient one is like due to either the mother is on some drugs or mother have some antibodies which have crossed the placenta, and now which is causing this problem in the children, right? Now the important thing over here to what you can say to discuss is basically the clinical features of this condition, and why, like what's the importance of this thing. So talking about the clinical features, like I will show you one photograph of a kid child, which is a hypothyroid child, right? And as well as you can see this one as well. So basically what happened, of course, like when we talk about the clinical features, so remember, like go in the same way, like the history, what you will found on the history, what you will found on the examination. So now when the children, they are born with hypothyroidism, most of them, they are asymptomatic in the neonatal stage, the first 28 days of life. What's the reason behind that is simply because the mother thyroid hormones which the baby acquire, or which are coming from the placenta, transplacental. So the T4 simply can cross the placenta and can be present in the baby. So of course, like that is the one which is making up the requirement. But after that, when that T4 is consumed, and now the baby cannot produce its, or like its own thyroid glands, and then they present with some sort of features, like they have prolonged jaundice. They, okay, now if you remember the features of hypothyroidism, they will be having constipation, they will be sluggish, they have hoarse cry, they are lethargic, their feeding is poor, and one of a very important thing, they have macroglossia. You can see over here the tongue is out, or the tongue is out, you can see over here. They have coarse facial features, you can appreciate over here. The features are coarse here. Their fontanelle is large, and they have umbilical hernia as well. So umbilical hernia is associated with congenital hypothyroidism. So when we see features like this, you see puffed up doll looking face, protruded tongue, okay, like this one. And see, this one is after treatment, alert looking, the baby look alert, and the swelling is less and the tongue is inside. So now, because you had done the thyroid in internal medicine, simply we diagnose them by, okay, one of the thing, by the way, diagnosis, okay. So of course, like diagnosis is by history, uh, with an examination, which I already discussed, and then of course, like now, the important thing, because this is the most important preventable cause of intellectual disability or mental retardation. When the newborns are there, so we go do newborn screening. So among different screening tests we do, like for phenylketonuria, for galactosemia, for cystic fibrosis, not everywhere, but in many countries, we do neonatal screening of thyroid stimulating hormone or free T4. Now, why? Because uh, this one is preventable cause, and if there is anything, of course, we can treat that. And simply, whenever the patient they have um, hypothyroidism, so what should be the management? Now, this is like something, not a big thing. So that's why you just have to remember like how we treat thyroid hypothyroidism. Of course, there is no thyroid hormone, so we must give them that hormone. So you can say thyroxine replacement is given to these patients. Okay, why this thing is important, by guys? Because there is very good outcome when we start treating them within the first 1 to 2 months of their birth. Because if they are going to delay the treatment, okay, so you can say if there is delayed, you can say diagnosis and treatment, it may result in permanent um, developmental delay as well as or um, disability. Okay, so that's why, like, it is a preventable cause, and we can simply diagnose it, we can simply manage it. So so permanent so permanent developmental delay, and this one. So this is like about hypothyroidism. And talking about hyperthyroidism or congenital hyperthyroidism, uh, now this condition, guys, um, like the previous one, hypothyroidism is more common in females, but in this one, the males are equally involved as females. There is no like increased prevalence in any one of them, but the prevalence of congenital hyperthyroidism is way less than the uh, what you can say hypothyroidism, and it is sometimes also called as neonatal Graves' disease. And again, like it could be permanent uh, at hyperthyroidism, or it could be transient or short-lived congenital hypothyroidism. So now um, the primary one, of course, like uh, the primary causes of this condition is again like could be anything like hypothalamic issues or pituitary issues or thyroid gland disorders. So like different things can be there, of course. Now the important thing is that um, many of the times, what you can say, um, when the patient have hyperthyroidism, these patients, they should be diagnosed as soon as possible, of course, by because like this conditions, uh, thyroid conditions, they are manageable, they are treatable. Now the important thing over here to discuss is congenital Graves' disease is simply they show all the features of what you can say um, like we have in the adults. For example, um, whenever the babies they have hyperthyroidism, They have features of like, okay, the transient one, by the way, first of all, I must talk about this one. The transient one sometimes is due to when the mothers have um, hyperthyroidism, right, or Graves' disease. So what happens, like, the auto antibodies, the antibodies from the mother, they cross the placenta, and once they cross the placenta and they what you can say, they enter into the into the newborn. So what happens is simply, they started stimulating the thyroid, which will result into the formation of more and more thyroid hormone. And of course, like, once that antibodies simply stop acting on the thyroid, uh, it is going to it is going to go away. Okay, so that is like the how the transient cases, they present. Like, simply, they are short lived. Once the baby, they have this um, thyroid antibodies from the mother. For example, when the mother has Graves' disease, and due to that Graves' disease, what is there? Simply, Graves' disease is caused by its autoimmune condition, and it's autoimmune condition in which there is autoantibodies are formed um, against the thyroid, which are basically thyroid stimulating antibodies, and they attached onto the thyroid, and no matter, like, either the body need the thyroid hormone, or the body um, is not in the need of thyroid hormone, but they keep on stimulating and they keep on forming um, the thyroid hormones. And that's the reason what happens is, simply, um, the body keep on making more and more thyroid hormones, and there will be like the clinical features of hyperthyroidism started appearing. So of course, like, the baby don't have the Graves' disease, only the mother have the Graves' disease. Okay, so that's the reason. Like, once this antibodies are going to uh, go away or utilized, of course, the patient are going to come back to the normal state. So that's the transient. But of course, like, whenever it is permanent, so then it is going to be, what you can say, maybe an autoimmune condition in babies, right? So, or um, uh, like, it is going to live there, and it is going to cause a lot of problem. Okay, so now the features of hyperthyroidism in the babies, of course, they will be same like, um, what you can say, adults. They are going to have um, tachycardia, as well as they will be having sweating. Okay, like, these are the features which are same like the adults. Okay, they are irritable, and they may have what you can say, diarrhea, of course, like, same like adults. So when you feel their palms, it could be sweaty. Okay, and it could be sweaty, and maybe you will found a goiter or a enlarged gland in these babies on examination, of course. So you can say there could be an enlarged gland can be there. So now, whenever, like, we found hyperthyroidism in the baby, so what is the treatment for this one? Of course, like, we can use the same drugs as we use in the adults. Okay, one thing is this thing. So anti-thyroid drug therapy can be given, and we give them metimazole or uh, uh, carbimazole or methimazole, right? So carbimazole is the usual drug which is uh, given to the thyroid patients. But sometimes, of course, like when the children's they cannot tolerate carbimazole, we can put them on propyl thiouracil (PTU). So same like adults, like there is no difference, much difference. And of course, like we keep on monitoring their TSH level, like either the thyroid is controlled well or not. And the other treatments are same like adults, like we can go for surgery, we can go for iodine or radioactive iodine destruction in the children as well. So you can say like somehow the condition is almost like same. But the important topic, of course, like will be the hypothyroidism, not the hyperthyroidism, because hypothyroidism is more common and it can cause more trouble in the patients. Okay. Next is sexual development. Sexual development. Now, in sexual development, guys, first of all, we must know how the babies, their what you can say, they develop their gender. For that, like I will show you this one. Like, of course, when what you can say, we like there is a fetus, they have gonads, okay, which are undifferentiated. So now the important thing to remember is in the males, what is the genetic makeup of female? It's XX, okay, and what is the genetic makeup of male? It is XY. So uh, remember, it's the Y chromosome, or which have SRY gene, which is responsible for the differentiation of these gonads into the testes. So simply, see, the girl line is very easy. See, the females, they don't have Y chromosome, so they have X and X. So when they don't have Y, so they don't have SRY gene, and so when they don't have sex determining gene, so simply it develops into ovaries and female genitalia. But the males, where the genetic makeup is XY, so they have the Y chromosome, which is SRY gene, right? So uh, it is also called as a sex determining region of the on the Y chromosome. So because of this gene, we develop testes. And now, uh, what you can say, the testes, they have the cells, like one is Leydig cells and one is Sertoli cells. So simply, what happens is, you can see over here, um, Sertoli cells are the one which produces like anti-Mullerian hormone. And what is the function of this one? It inhibits uterus and fallopian tubes formation, right? So uh, when there is sex determining gene, the testes have these cells, and due to anti-Mullerian hormone, what happens, like they inhibit the formation of uterus and fallopian tube, right? So this is the first concept. Now the other thing to understand over here is Leydig cells. So Leydig cells are those which are going to produce testosterone. Now when they produce testosterone, what happens is testosterone are the one which are responsible to maintain the male internal genitalia, like which is vas and cords and seminal vesicles. And again, testosterone is the one which is again responsible. There is a enzyme called as 5 alpha reductase, which change into dihydrotestosterone, and then it is responsible for virilization of the external genitalia. Now, although it's not so common, but of course, the children can born with some uh, issue with the you can say, sexual differentiation. Okay, so whenever there is sexual differentiation disorder, we call it as like we can see clinically when we examine the kids. Okay, so that's why uh, we examine the genitalia of the newborns. Uh, we are going to study some important conditions in this one. One is called as congenital adrenal hyperplasia. and we are going to study some other conditions. For example, one is called as androgen insensitivity syndrome. So, uh, when there is androgen indeficiencies, what you can say, androgen uh, insensitivity syndrome. Okay, so of course, like the body is not responding to the androgens, which is testosterone in this case. So what happens? Simply, um, sometimes the body cannot produce androgens. Okay, or sometimes, for example, there is 5 alpha reductase in a deficiency. So what will happen? Like testosterone will not be changed into dihydrotestosterone. So what will happen? There will be decreased virilization of the external genitalia. Okay, so this thing is one of them. So what I wanted to show you over here is, for example, this one. See, um, if you will see this photograph, what you are going to find it like it's hard to differentiate either it's a male or a female. You can see like how his testes look like, or you can see like how his penis look like. It looks like, see, there is like it's a clitoris. Okay, or you can see over here one more photograph I want to show you is this one. Like this one is like androgen insensitivity syndromes. So you can say like in this one there is partial androgen insensitivity in this case, and you can see uh, there is labioscrotal fold. So this one is not labia, this one is not scrotum. So very hard to identify the sex of the baby. Or this one is like the less severe partial androgen insensitivity syndrome, in which like see the condition is better than this one, right? So, but still like this is not the normal how it normally appears. So now what we call it as when someone have genitalia like this, what you call it as ambiguous genitalia. Okay, simply see, you cannot appreciate either it's a male genitalia or it's a female genitalia. So it's hard to differentiate, so we call it as what? Ambiguous genitalia. Now simply, so what is an ambiguous genitalia? It's simply when it's difficult to uh, you can say it's difficult to assign a gender to a newborn based on the appearance of genitalia. Of course, if the appearance of the genitalia is like male, so we will say that it's a male. But if the appearance of the genitalia is not like is like female, we will say it's a female. But if it's like some ambiguous genitalia, which I show you already, then of course like it's hard to assign the gender based on the look of the genitalia, and we call it as disorders of sexual differentiation, or DSD. Okay, so it is also called as disorder of sexual development or disorder of sexual differentiation. So anything you can say. uh, so simply, what is disorder of sexual uh, differentiation is simply a condition uh, in which development of chromosomal uh, or gonadal or anatomic sex is atypical, like not like typical but atypical. Okay, and of course like there are different type of what you can say uh, disorders of sexual differentiation. For example, one is called as 46 uh, um, 46XX. One is 46 XY, and one is called as ovo testicular disorder of sexual differentiation. It is also called as true hermaphrodite. Now, the incidence of these genital abnormalities at birth is quite high. You can say 1 in 300 births, they have this thing. Um, but this thing. So what happens in in these patients? Like, what is the etiology behind 46XX or 46XY or ovotesticular DSD? In this one, like, we are going to study just one condition that is called as congenital adrenal hyperplasia. Uh, now, I will talk about this one again. Back to this one. So, if I will talk about 46XY, so of course, like, Y chromosome is there. But what happens in these babies? Uh, they have inborn error of testosterone biosynthesis. Like, simply, either they have, you can say, hypoplastic Leydig cells, like their Leydig cells cannot produce testosterone normally, or maybe the Leydig cells are not hypoplastic, but they cannot function properly, or they have some, you can say, error in the production of testosterone. Okay, this is one of the cause. Maybe they may have alpha 5 alpha reductase deficiency, or maybe they have, again, I show you that photograph, androgen receptor deficiency. So see, this can be the case as well. Like, they have this androgens, but of course, like, these androgens, they should go and act on the receptors. So maybe the receptors, they are insensitive. They cannot respond to this hormone. So this is one of the cause, right? Or this is what happens in 46XY disorder of sexual differentiation. So what will happen? Simply, what is going to happen? See, this is the place where there is error. So see, uh, they cannot maintain vas deferens or cords or seminal vesicles, and there will be no virilization of the external genitalia. See, so go logically. So this thing will be not there, okay? But there will be inhibition of uterus and fallopian tubes. Now, there is 46XX, okay, which means we must come over here. This is the most common one. 46XX is the most common one, and it is also called as congenital adrenal hyperplasia. So there could be many reasons behind that. So we are going to study this one in detail, okay? Now, there are people like the third type, which I told you, ovotesticular. These are the babies who have both um, ovarian follicles as well as these tubules, okay, in the same patient, okay. Their main genetic makeup is basically 46XX, but they have both of the things. So it is also called as mixed gonadal dysgenesis. Of course, like, there are different risk factors behind these things. Like, sometimes there is positive family history, uh, things like this. Sometimes, like, if the mother is using during pregnancy some drugs like androgens or progesterone or phenytoin drugs like this, so these things can occur. And in cousin marriages, these kind of things are very, very, very common. So simply, whenever, of course, like, uh, we diagnose, of course, this condition, like, we see, like, there is ambiguous genitalia, then we do the physical examination completely. We check, like, we, of course, will send them for karyotyping. Karyotyping will tell us either they have XY or XX. So if they have XY, for example, it means like they are male pseudo hermaphrodite, or if they have XX, so it is they are female pseudo hermaphrodite. So of course, like, if they have XY, maybe they will be having, you can say, a small phallus, see, a very small penis, okay, and it is presented with hypospadiasis, in which the urethral opening is not at the normal place, but rather down, and they have undescended testes. And whenever it is XX type, usually it comes with, you can say, see this one, clitoral, uh, like, it looks like clitoral, so clitoral hypertrophy can be there, or labioscrotal fusion. You can see, like, there's fusion over here. So this is like how we do. And of course, like, we do investigations. We see what is the thing which is causing this thing. Now, um, to talk about what you can say, Congenital adrenal hyperplasia, I will tell you what it is. So, uh, congenital uh, congenital adrenal hyperplasia. It is also called a CAH. Okay. Now, why this thing is important? Because this is the most common cause of ambiguous genitalia. Ambiguous genitalia. Okay, and uh, genotypically, they are basically females. Like their sexual makeup is 46XX, so they are like genetically they are females, right? So how we define them, again, it's a autosomal uh, recessive disorder. It's autosomal recessive disorder. It is characterized by uh, partial or total defect of various synthetic uh, enzymes required for cortisol and aldosterone production. Now, if you know where is cortisol and aldosterone is produced, so they are produced in the adrenal cortex, right? So if you know, like the adrenal medulla is the one which is which is forming the epinephrine and norepinephrine. So uh, now, to make you understand this condition, guys, I will show you this thing. This is the best thing to understand. Uh, if you know, like, what is adrenocorticotropic hormone? This one is released by the pituitary, and then we need cholesterol as a what you can say as the precursor from which many things are formed. And what's this thing is going on where? In the adrenal cortex. Okay, so adrenal cortex is the one which is producing the mineralocorticoids, which is aldosterone, or glucocorticoids, which is cortisol, or sex hormone, which is testosterone. So this is like we are talking about adrenal cortex, right? So see, like cholesterol is the one which is needed to produce all these things. And okay, this one is the most simplified form. Of course, there is a lot of enzymes. There is an enzyme here, there is an enzyme here, there is an enzyme here, and there are many steps between them. But this is like to make you understand. You can see over here, uh, most commonly in 95% of the congenital adrenal hyperplasia cases, this one is missing, 21 hydroxylase. It could be due to 11 hydroxylase deficiency. It could be due to 17 hydroxylase deficiency. It could be due to some other enzymes deficiency, but most commonly it is due to that. So remember about this thing, that 21 hydroxylase is the most common thing or enzyme which is missing of, which is responsible for causing congenital adrenal hyperplasia. So now what will happen when there is missing enzyme? So of course progesterone cannot be converted into aldosterone, so in the body the aldosterone will be less, and simply 17 alpha hydroxyprogesterone will not be able to make cortisol, so cortisol will be less. So what will have happen, of course, like they are sending negative feedback to the brain, and they are saying like produce more, like the body has deficient in these two, so produce more and more ACTH. So more and more ACTH will be produced. It will act on the adrenal cortex again and again and again, trying to stimulate that. And what will happen? The enzyme is missing, so and all these things are diverted towards where? In forming of what? Dihydroepiandrosterone. So this will be raised, and androstenedione, this one will be raised, or testosterone will be raised. Because see, these things cannot be formed but this hormone is going to activate and will keep on leading to adrenal cortex to work more and more. But of course, like it cannot be able to produce this thing. Why? Because the enzymes are missing. So ultimately, what will happen that there will be hyperplasia of the adrenal cortex. Okay, that's what is called as congenital adrenal hyperplasia. So see, when we will do the bloods of these patients, we'll found increased ACTH, we will found decreased aldosterone, decreased cortisol, but increased testosterone and increased DHE is. So now uh, the presentation basically depends on which enzyme is deficient. So why, for example, if this enzyme is deficient or this enzyme is deficient, and as I told you, this is the simplified form. There could be other enzymes which can be deficient, but uh, the most common is 21 hydroxylase. So I'm going to talk about that thing. So now, whenever it is due to 21 hydroxylase deficiency, we call it as we classify them as you can say classic deficiency with salt wasting. I will explain you this thing what it is. And the other one is we call it as classic deficiency without salt wasting. Without salt wasting. Okay. Uh, you will understand what it means. And then there is non-classic one as well. Okay. So the classic one can be with salt wasting. So non-classic congenital adrenal hyperplasia. Okay. So what happens? See, what is deficient now? Aldosterone is deficient. So what is the function of aldosterone, guys? I think now you guys know what is the function of aldosterone. Whenever aldosterone is released, so it is going to uh, uh, absorb more and more sodium in the body. But in this one, aldosterone is deficient. So what will happen? Like the patient will lose more and more sodium, and the body will retain more and more potassium. So they will present with hyperkalemia and hyponatremia. Uh, so that's why it is called as, because there is hyponatremia, it is called a salt wasting one. The classic deficiency with salt wasting. So the babies will present with failure to thrive. They will be presenting with vomiting, acidosis, hypoglycemia, and things like this. So and in the classic one without salt wasting, uh, now what happens in these patients is simply uh, they have virilization. Why? Because what is responsible for virilization? It is the testosterone. Remember, it is the testosterone virilization. So they will be having, you can say, virilization because the testosterone is more, okay, but their aldosterone levels are quite normal, so they don't present with salt wasting. But like they do present with, you can say, virilization, right? But no salt wasting. So the same. And the non-classic one, or the non-classic congenital adrenal hyperplasia, how they present is like they have mild androgen excess, like these are more, okay, and they are sometimes asymptomatic, but virilization is present later in the life, okay, later in the life. This thing is important. Now, guys, see, whenever there is deficiency of cortisol and aldosterone, if you know the function of these things, you must know, like, there will be hypotension, and cortisols are very, very, very important for the body to function normally. Okay, so all the things will be present. So now 21 hydroxylase is a part of screening in many countries when there is a newborn baby. So they always check, okay, either the baby is deficient in this one or not. Now, simply when there is deficiency of this one, what will accumulate in the body? This one will accumulate in the body, right? This one, this one, this one. So again, we can do what kind of test? We can check this one. Okay. We will found, when we will do the bloods, we'll found ACTH will be high. We'll found hyponatremia. We'll found hyperkalemia. We can found hypoglycemia because the cortisols are less. We can found this one higher and these things higher in the blood. And when we will do ultrasound, what we'll found? We'll found that the adrenal glands, there is hyperplasia. They have hyperplasia. Okay. So this is how they present, and how we treat them is simply by management. Of course, it's an emergency, so because there is hyponatremia, there is hyperkalemia, there is acidosis, so admit them, okay, or you can say ABC, correct the electrolyte abnormalities in the patient, okay. Serum glucose levels should be maintained, okay, should be checked, and deal with that. Give them IV fluids, okay, this is very important because they are hypotensive. Now what is missing? Cortisol. So provide um, glucocorticoids, okay. What we give them hydrocortisone injections. And what is missing? Aldosterone. So provide them with mineralocorticoids, okay. Why? Because aldosterone is missing. So what we can give for this one, we can give them hydrocortisone. What we can give for this one, we can give them fludrocortisone, okay. So and of course, remember, like whenever there is any infection, stress, surgery and things like this, the requirement of these things is increased, okay. Now what are the other things they have is virilization. So treat the, you can say, secondary um, issues, of course, like virilization, acne is more, all these things, of course, we must treat them with this thing. So this is how we manage congenital adrenal hyperplasia. So after that, guys, uh, I think we must talk about, not so important, but because we are talking about this ambiguous genitalia and congenital adrenal hyperplasia, we must talk about the normal pubertal development. Now, how the puberty is reached? Simply, there is a hypothalamus pituitary gonadal axis. Uh, what happens is, um, right, okay, don't see these things right now, but this is the hypothalamus is there, which is releasing the what you can say uh, gonadotropin releasing hormones, and then what will happen that LH and FSH are formed and they are released and they go onto the gonads, okay. So gonads means what? Like testes in males and ovaries in females, right? So what happens, like when there is increase in the pulsatile release of the gonadotropin releasing hormone, the pituitary start producing LH and FSH. They go and act on the gonads, and if it's a male, their testes will started making testosterone, and if it's a female, their ovaries will start making uh, estrogen. Okay, so simply, or you can say the sexual hormones. So like they are going to produce the sex hormones, and that's how the secondary sexual characteristics started appearing. So now we use something called as Tanner staging. Like in females, the onset of puberty is around 8 to 13 years of age. Okay, wait, I will write it down because I can get confused as well. So in females, the puberty uh, reached, you can say, by 8 to 13 years of age. Okay, uh, now the sequence is something like this. So first one is telarch, and then there is um, pubarch, and then there is growth, and then there is menarche. Now, what is this, by the way? Telarch is the Telarch is the formation of the breast. Okay, pubarch is, or you can not formation, rather the formation of the breast birds. Pubarch is the hairs, like axillary hairs or pubic hairs. Uh, the females, they have mild acne, and growth spurt is like when they started achieving or they started gaining height. And menarche is like, of course, onset of menses. So menarche age is around 12.5 years on an average. Okay. uh, Whenever there is menarche in females, remember the growth spurt is completed. Okay. So when the growth spurt is completed, like they have this menarche. Okay. One very important concept to remember is early puberty is very common in females, but late puberty is rare. Okay. So early puberty is common. Now it's very important clinical point. It's common, but late puberty is rare. Okay. So when the parents or like the guardians bring the child and say, like, like, eh, they are very less age and they started showing the signs of puberty, so nothing to worry about. But when the puberty is not reached, so late puberty in females is rare, so always investigate. Okay. In males, the puberty onset is 9 to 14 years of age. Okay. And the sequence is, number one is testicular enlargement. Okay. Secondly, they have penile enlargement. Then they have pubarch, and the last one is growth spurt. Growth spurt. Okay, so simply their testes enlarge first of all, then penile enlarge, and then pubarch means like their axillary hairs, their facial hairs, and acne, for example, and growth spurt is the last one which occurs. Now, again, one more important clinical point is, in this one, early puberty is uncommon. Okay, but late puberty is common. So, see, whenever a male, a boy, is showing the signs of early puberty, so always look for the organic causes. And whenever like there is late puberty, so we can ask them that they can wait. Like, and it is often constitutional. Constitutional means like it is going to catch up. The baby is going to catch up. One thing which can occur during this time is gynecomastia. Gynecomastia is like the development of breast tissue in males. So it is a self-limited condition. So very, very, very common. Up to 50% of the males or boys, they may have gynecomastia. Okay, so this thing. Now, one of the thing which we can do or which we check is called as Tanner staging. So what is Tanner staging? Simply it's whenever the patients, you can say, they are pediatric patients, of course, they are brought to the doctor. So they use this Tanner staging scale, or the scale is basically used to define the physical measurements or development based on the sexual characteristics. So, for example, like this one is for boys, right? So this is like Tanner staging for boys. Uh, this is stage 1, this is stage 2, stage 3, stage 4, and stage 5. Okay. So now you can see over here, stage 1 is like there is no hair. Stage 2, there is a small amount of long, straight, or curled, slightly pigmented hairs along the base of the penis only, right? And enlargement of the testes and scrotum is there, and there is reddening of the scrotal skin. Stage 3 is like that, that the hairs become darker and coarser, curlier, and the penis is also like enlarged, as well as the scrotum is more enlarged. And stage 4 is there is adult type of hairs, and uh, and it reached to the medial side of the thighs as well. Okay, and stage 5 is like, you can say, same like adult. Okay, so this thing, and this one is like the same thing they are showing you, just genitalia they remove the hairs. And this one is for the females, stage 1, stage 2, 3, 4, 5. This one is for the breast bud, showing from front and showing from side, and this one is for the pubic hairs. So this is the chart we use, like the scale we use to see like what is the tenor staging of of that patient. Okay, so you can say stage 1 is like, there is just a slight elevation of the papilla. Stage 2, like there is a breast bud, breast and papilla are elevated. Stage 3 is like enlargement is there of the breast and areola, but the contour is like not so obvious. And stage 4 is like the areola started forming, and stage 5 is like same like mature, nipples are projected, and same like adults, right? And this is like for the pubic hairs in females. So now one of the thing, guys, is called as uh, uh, one of the thing, is called as precocious puberty. So simply, precocious puberty uh, is simply uh, when the development of secondary characteristic, uh, development of secondary sexual characteristics, especially less than 8 years of age in females and less than 9 years of age in males. Okay, so now uh, remember I told you start of the puberty is very common, early puberty is very common in females. So this is simply early puberty. So simply this is more common in females than males, right? This is called as precocious puberty. And then there is something called as delayed puberty. Now, delayed puberty can simply be defined as again failure. This should be failure, right? Failure of to develop secondary sexual characteristics. Okay. Okay. For males, it is lack of testicular enlargement by 14 years of age. Okay, and for females, by the way, this one is different for Africans and different for different ethnic groups. Like in African race, precocious puberty or the onset of puberty in females especially is taken happen earlier than the rest. So it is lack of breast development by 13 years of age, or absence of menarche by 16 years of age. Okay, so this is like what you can say delayed puberty. Now, as I told you, a delayed puberty is more common in males, so it is more common like if there is delayed puberty in females, investigate, and if there is delayed puberty in males, so reassurance can be done, right? Uh, Now, guys, the important thing to quickly wind up this topic. First of all, like I must tell you that if you don't know the basics, especially about what you can say, how this hypothalamic pituitary gonadal axis works, like it will be hard for you to understand. But for example, like these are the causes of precocious or like early puberty, right? So now it is usually idiopathic in females, but whenever it occurs in males, most of the time it is a pathology. Now you can see um, over here and over here. See, this is gonadotrophic dependent, and this is gonadotrophic independent. Why? I will tell you now. See, LH and FSH are raised. Okay, LH is more than FSH. Pituitary is releasing LH and FSH, which are acting on the gonads, and the gonads are releasing estrogen from ovaries or testosterone from testes, okay, or adrenals. And of course, like once they will be released, there will be breast enlargement or pubic hair growth happening or body odor. Okay. Um, Now, see, what happens in these patients is simply we divide into gonadotrophin dependent or central, or gonadotrophin independent or uh, peripheral. Okay. Now, what's the reason? Simply, this one is also called as hypergonadotrophic. See, these are the gonadotrophins, hypergonadotrophic, and they are producing the hormones. So, hypergonadism. So, this one is also called as what? Hypergonadotrophic hypergonadism. Okay. So, what are the causes? Like, it could be, you can say, idiopathic or familial, as in females. It could be CNS abnormalities like congenital abnormalities like hydrocephalus, or acquired like post-radiation infection, surgery, tumors, microscopic hematomas, or hypothyroidism. Okay, so what is going on? See, um, simply, it is central. It is also called as central, or it is also called as gonadotrophin dependent, or it is also called as hypergonadotrophic hypergonadism. So what is going on? See, the gonadotrophins are released more, so they are acting on the gonads and they are forming the sex hormones, right? So these are the causes. Coming on this one, which is the peripheral one or gonadotrophic independent. See, what's going on? For example, someone have a tumor in the ovary. Like, listen to me carefully. Someone have a tumor in the ovary, or someone, for example, have congenital adrenal hyperplasia. Okay, so, or someone have, for example, a tumor in the testes. So see, when there's a tumor here or here, what will happen? That tumor is going to produce more and more testosterone in this case, or estrogen in this case. So when more and more estrogen and testosterone are formed in this one, which is not in the control of pituitary, so what will happen? Of course, like there will be features of precocious puberty, but in the body the sex hormones are more. So when the sex hormones are more, there will be feedback mechanism, and LH and FSH will be depressed, and there will be decreased LH and FSH in the blood. So in this one, we will found increased sex hormones and increased gonadotrophins. In this one, we are going to found increased sex hormones and decreased gonadotrophins. So that's why it is also called as hypogonadotrophic hypergonadism. And what are the causes? You can say it could be uh, adrenal disorders, tumors, congenital adrenal hyperplasia, ovarian tumors, testicular tumors, or someone who is taking steroids or sex steroids, right? And there are many other causes as well, which can be there. So now, guys, whenever we found a case of precocious or early puberty, we first of all we check the symptoms of puberty, which, or you can say the tenor staging you will do, right? Very, very, very important. We will take the family history of precocious puberty. We are going to take the history of medical illnesses, because see, a lot of medical illnesses can cause. Then we will do the physical exam. We will check their growth velocity, and we will check like either they reach the growth spurt or not, and we will do the tenor staging, and then we do go for the investigations based, like depending based on the cause we are going to find out. For example, you can do, if you remember my previous lecture, you can check their bone age. We will check their estradiol levels, we will check their testosterone levels, we will check their LSH level, LH level, and FSH level. Now thyroid causes can be there, so we can check their thyroid hormone levels. We will, like, congenital adrenal hyperplasia is there, we will check like 21 hydroxylase, or 71 hydroxylase, or DHEAs, or all these things. uh, Tumors are the causes. We can go for ultrasonography, we can go for MRI, so MRI of or CT scan of the abdomen, or central causes, MRI of the brain, simply to catch this thing. So, like, of course, all the investigations are can be done, and the management is simply treat the underlying cause. Um, Now, as you know that we know, like, in females it is quite common, but in males it is not so common. The important one of the risk is, like, in early puberty, like, there could be the risk of early closure of the epiphyseal uh, plates, and the baby, they cannot reach their adult height, or the normal height. So in that case, we can give them, what you can say, some drugs like leoprolide, okay, so that we give them time to reach their, like, height, okay. So in the peripheral causes, of course, when there is some tumors, we have to control the production of these hormones. In that case, we can go for surgeries, or we can give them medications, like, uh, you can say, there are drugs which can block the effects of these sex steroids, like ketoconazole is there, or spironolactone can be given, this thing. And same thing, guys. So remember, this thing is also called as what? Hypergonadotrophic hypergonadism. So gonadism means what? The gonads are working more. This is also called as hypogonadotrophic hypergonadism. Okay, because the gonadotrophins are less, but gonads are working more. Okay, so same thing. If we will talk about in delayed puberty, okay, what are the causes of delayed puberty? So if we'll talk about the causes of delayed puberty, wait, let me create some space over here. The etiology. Now, delayed puberty is very common, or it's constitutional. It is called as constitutional delay in males, but most of commonly, delayed puberty have organic pathologies in females. So, the most common cause of delayed puberty in males is constitutional delay, right? So, it could be central again. The central causes can be there, or you can say there could be peripheral causes. So, same like the previous one. Okay. Now, in central causes, of course, like if there is delayed puberty, so one of the most common causes is constitutional delay, right? But in males, constitutional delay, you will found the family history. And the other thing, the central causes, so now the brain is not producing gonadotrophins, and that's why the gonads are not producing sex hormones. So simply, it is also called as hypogonadotrophic hypogonadism. Okay, so this thing. And when it is peripheral causes, so what it will be called as, like, peripheral causes, of course, like the gonadotrophin hormones are coming from the brain, hypergonadotropic hypogonadism. For example, I will give you the example of this thing. The brain is working fine, but the ovaries and testes, they are not responding to that. For example, a very good example of this thing is called as Turner syndrome. In Turner syndrome, the ovaries are uh, not functioning, or there is ovarian dysgenesis. So what happens is like, whatever, like the LH and FSH are coming, but the ovaries are not there, so they will not produce estrogens. So now, or one more example of this thing is also called as androgen insensitivity syndrome, which I've already talked about before. So same way, we will take the history, we will do the physical examination, we will use the Tanner staging, we will do somehow the same investigations, the bone age, we will check the serum hormone levels. Based on that, we can say either it's hypogonadotrophic or hypergonadotrophic hypogonadism. Okay, uh, we will do the CBC, LFTs, MRI, or ultrasonographies, or all these things, like simply to identify the causes. Karyotyping for Turner syndrome. Okay, so we are going to do all these things, and of course, like treatment is simply treat the underlying cause, as well as what is the other thing we can do. You can say hormone replacement should be given. Of course, like in the females, we give them progesterone or estrogen, and males we give them testosterone. So I hope, guys, you understand these things. Okay, we have still a lot of topics of pediatrics left, like GIT, respiratory, infectious diseases. So and also syndromes like Down syndrome and Turner syndrome we have to cover. So see you guys next week. I hope you understand. Thank you.